So we're going to do a very quick switch here to the next panel. I think, as was clear from the previous discussion, the U.S. is an outlier, but now we're going to talk about the U.S. in greater depth. And we have a incredibly knowledgeable panel here. And I'll do very quick introductions, but as Cynthia said, the bios are all online and available. So we'll start at the far left, so to speak. Marty Gaynor is a professor at Carnegie Mellon and a former economist at the Federal Trade Commission. Robert Murray is former executive director of Maryland's Cost Review Commission, Maryland being the only remaining state to have an all-payer rate-setting system for hospitals. Jenny Bryant is senior vice president at Pharma, who I think is probably having a very busy week this week. Chris, although every week is busy in healthcare, right? Chris Haltmeyer is vice president of the Blue Cross Blue Shield Association, and Melinda Hatton is general counsel of the American Hospital Association. We're going to do a sort of interactive, spirited discussion here that hopefully won't turn into a brawl. I have all the confidence that it won't. And then we'll leave time for audience questions as well. So Marty, let me, you're the non-player here, the observer. Are there reasons to believe, particularly given that previous conversation, that healthcare prices, we know healthcare prices in the U.S. are higher than other countries, we know they've been growing faster than inflation, but are there reasons to believe that prices are higher than they should be in an economic sense? And if so, what would you say are the reasons behind that?
Yeah, that's an excellent question, and I think the way you preface it, Larry, is important. The fact that prices are high or that they're growing rapidly is not necessarily meaningful in and of itself. And I think we also have to be very careful to distinguish between prices for different kinds of products. So for example, pharmaceuticals have taken an awful lot of heat about pricing, some of it justified, but some of it unjustified. So if there are new products that are extraordinarily valuable and also extraordinarily costly to develop, like Sovaldi, a cure for hepatitis C, that drug is going to be expensive, but it's also extraordinarily valuable. Hospitals often treat very complex, costly patients. Prices will be high for those kind of things. And having said that, I think one thing that we consistently see is that prices for every part of healthcare, be it insurance, hospital sector, physician practices, pharmaceuticals, are higher where there's less competition. And I do think that we have a competition problem, not every single part of the country, not every single sector, but as people know, there's been a tremendous amount of consolidation in every part of the healthcare industry. Again, I want to be careful, not all consolidation is bad, some of it's beneficial, but there's been a lot of it that's been between very close competitors, and when that happens, that competition is eliminated, and we lose that competition, prices go up, quality tends to go down, incumbents get entrenched and reified, and we get less innovation and benefits for all of us.
Great. So, Melinda, let me turn to you. We talk a lot about drugs. Hospitals are actually the biggest sector of the health system, and remain so. Hospitals operate, as we talked about in the previous panel, hospitals operate under a highly regulated system among public payers, Medicare and Medicaid, but private prices are now coming under greater scrutiny. How do you respond to Marty's point? Others made this point that it's consolidation that is driving these prices and making prices too high in some cases. And are there steps the industry would support to moderate prices?
And just so the audience knows, we had no idea what these questions are going to be, so all our answers are going to be free form, I think.
Yep, free form is great.
Unless you were cheating.
No, free form is great.
We've looked carefully at this issue in a number of ways, and we don't think consolidation is the issue. No, I think you put your finger, and listening to some of the presentations beforehand, on one of the things that really drives high prices, or higher prices than they should be, in U.S., and not just for hospital services, but for other services, is regulation. Is the overabundance of regulation in this area. It is just really astonishing. For example, I was looking at the paper that Marty released last night, and he makes a very, I think, unremarkable observation that prices are higher in a California hospital than they are in a Louisiana hospital. Well, there's no surprise there. California has an enormous, complex regulatory regime that I think is really unparalleled. We have looked at some of the drivers of higher prices, and regulation is a huge contributor. The other, and you mentioned the private side, the other driver on the private side is that the government, both Medicare and Medicaid, which make up 50% or more of almost all hospitals' revenues, are conspicuous underpayers. They underpay by anywhere from 10 to 12%, 15% more the cost of actually delivering services. So it's not very surprising that private insurance would have to pick up some of that slack. I could mention that the cost of the cost of dealing with multiple insurers, the high cost of drugs, all of these contribute to what we see to hospital prices. To the difference in hospital prices. One other thing I should mention is that, particularly in the hospital field, that we're seeing a huge change in the field from patients being patients being treated inpatient to outpatient. And when you get to the outpatient sector, you're really talking about a whole new playing field for competition, where we see, and I think you all see, disruptors every day. Look at the CVS announced deal. Look at Walmart's I think on the verge of making a deal. So there's really a lot, I think, and I don't think you can look at consolidation as a driver of hospital prices.
So Chris, I mean, our system on the private side operates on the idea, and we talked about this in the previous panel as well, that you have private insurers negotiating with health plans, with physicians, indirectly with pharmaceutical manufacturers. So it's a bit of a challenge to you when prices are rising faster than inflation. Kind of as a plan, what do you see? I mean, first, do you see price as a primary driver here of cost growth, similar to the study that Jay mentioned? And what's standing in your way in negotiating the kind of prices we see, or the kind of price growth we see in other countries?
Yeah, thank you. If you look at the impact of healthcare costs over the last few years, it really has been about the prices. So if you look at utilization across most categories of services, from commercial health plans, Blues, and others, you see that utilization is flat or down across most categories of services, but prices are up. So in the area of inpatient hospital services, for example, from 2012 to 2016, prices are up about 25%, the same for pharmaceuticals. Utilization of inpatient hospital care, as was mentioned, is down dramatically, so overall spending hasn't been as much of an issue there, but certainly it has for drugs, where we see the spending has gone up about 27% over that same period. What we do about that from a private sector standpoint is a number of things. We work to negotiate with providers. We try to change the way that healthcare is paid. We try to make consumers more prudent purchasers of care. All of those things require competition in some way. I think one thing we've seen over the last few years is a dramatic growth in value-based care arrangements. In the Blues system, we now have 62 million members who are getting their care through value-based payment arrangements. That does require a competitive healthcare sector. So the question has come up about, should we move to Medicare payments for all? Would health plans like to be able to resort to Medicare payments? We really aren't in favor of administered pricing. I think that would lock in place a lot of things that would really undermine competition. But we do need that competitive healthcare system. So we do need competition in the hospital sector, and there's some concern about acquisition of physician practices and what that may mean over the long term. We're concerned concerned about pockets across the country where health plans really have a difficult time negotiating with providers. This has been the case in dialysis in certain areas for physicians. And we really do need a competitive system for drugs where there's a broader access to generics, a competition for brands, and then we definitely have to address this question of more personalized medicines and how we assure transparency there so we could afford some of the breakthrough medicines coming down the pike.
Well, speaking of drugs, I think in some sense the fundamental question when you look at the international comparisons, and drugs are different from other sectors of the health system in that it's the same product, and the product can travel internationally. That's harder for hospital and physician services. So, what is the argument? Why should the U.S. be paying higher prices for drugs? And similar to my question to Melinda, I mean, are there things the pharmaceutical industry would support to bring the price of drugs down or moderate the growth?
Sure. So, I mean, I think just to be clear, we believe that there's a really big access problem in this country and that we have a lot that we need to do to address affordability for patients. So I don't think you're going to find manufacturers saying, well, there's nothing that we need to be doing. We believe there's a lot that can be done to address prices in this country. I would maybe say that this problem often is sort of taken out of context and that there are many drugs that actually are not more expensive in the U.S. than in other countries. And particularly if you look at like what we pay in Medicaid, we have many drugs that are essentially free practically in Medicaid, where other countries definitely do pay more. But that said, there are a lot of drugs that do cost more here, and we think that we have a system that also delivers more for patients. But that doesn't mean that we don't have a lot that we can do. And we've been very aggressive in talking about the fact that every year there are more and more discounts that are negotiated by manufacturers with insurers, and we believe those need to find their way to patients. We think sometimes they get lost along the way, and that for very competitive classes where the prices have not been rising, you see patients paying too much at the pharmacy counter, and we think that there's a lot that needs to be done there. That's one example. We think there's a lot more that can be done to find new ways of paying for medicines. Chris referenced value-based payments. We think that's a very amorphous term, but that there's a lot that needs to be done to sort of modernize the way that we pay for new medicines so that we can take full advantage of the new therapies. So prices could be better tied to outcomes. We have manufacturers who want to do things like, essentially all-you-can-eat pricing. There's a lot to talk about there. And another thing that we are focused on, unfortunately, is that there's a lot of distortion in the market now for prescription drugs because of a bigger and bigger disconnect between the sticker price and the net price. So as discounts go up, there's more and more of this disconnect, and that leads to not just problems for patients, but problems for the whole system. And so we're seeing a lot of examples where essentially hospitals or PBMs, others can buy low, sell high, and make money on the spread. And I think we would like to see that addressed. There are a number of ways to do that. Reforming the 340B program would be one example of that. But we think it's a problem when people can buy a medicine for a few pennies and sell it for a few $1,000s. Like, that's just not a system that leads to efficient competition. So those are the kinds of things I think we'd like to focus on. But it's all about making sure that patients can afford their medicines. And there's a lot that needs to be done, I would argue, on cost sharing too, because as we have more and more expensive medicines that are sort of closer in cost to, say, a hospital stay, we think it's a little bit unreasonable to ask people to pay their full 12 months of cost sharing in 6 weeks at the start of the year. You're sort of taking an annual year of cost sharing, cramming it into 6 months and expecting that patients have enough in their savings accounts to pay for it. We don't think that works. We also don't think it's reasonable to ask cancer patients who don't have alternative lower costs of therapy to be paying 45% coinsurance just because because a health plan can do that. I mean, we think that cost sharing should be about trying to drive the most appropriate form of therapy, not trying to just pile on to the sickest patients. So there's a lot, I think, that we can work on and that we should work on.
Great. Well, finally, Robert, let me turn to you. I mean, Maryland's kind of the state of the moment in healthcare prices. Historically, there were a number of states that had all-payer rate-setting systems for hospitals. Maryland is the only one standing. Give us just a really brief. You ran the system. Give us a very kind of brief description of how the Maryland system works and how it's evolved, and also whether, in your view, it's actually been successful at reducing price growth in hospitals.
Sure. I should preface my statements by saying I think it's absolutely the issue with regard to that we're facing now, and the topic of this forum. It's all about purchasing power. You have a system in the United States. We have a very fragmented set of purchasers, particularly in the private sector, in private insurance, facing a very consolidated healthcare industry, hospitals in particular, but also integrating vertically and horizontally. Two ways to address that. One is you try to restore that competitive balance, and you can do that through antitrust activity. Unfortunately, the cows are basically all out of the barn in that area. Or you set prices, you set limits. Maryland has approached it the latter approach. Very briefly, I'll try to summarize the system. It's a very complicated system. We, back in 1971, set up the system. We implemented it as an all-payer system by getting a waiver from Medicare in 1977. We were one of 4 states to have all-payer rate setting. Interestingly enough, in the 60s and 70s, as many as 27 states had some form of rate setting at that point in time. The differences in payment levels were between private payers and governmental payers relatively narrow at that point in time, so it allowed us to set rates that were consistent across payers back in 1977. The hospitals, interestingly enough, supported the legislation. Dick Davidson, who was the president of the AHA at the time, was at the Maryland Hospital Association and saw the value of having a system that would create financial stability for the hospitals, but at the same time pay for uncompensated care and provide other benefits. The mechanics are you have an independent agency. There's a Health Services Cost Review Commission in Maryland that set rates formulaically, where you establish rates initially based on cost, historical costs, and then you trend those rates forward prospectively. That transfers risk from the payer to the hospital, creates the incentives for cost control. Over time, what we did is we tried to expand the bundle of payment. Initially, unit rates. We went to DRGs in 1977. We were the first state to do a jurisdiction to do DRGs. And then over time, we've expanded that bundle of payments so that now you have global budgets. And that transfers more financial risk to hospitals and has stronger incentives for cost containment. In terms of the pros and cons of rate setting, it can be very effective in terms of controlling costs if it's designed well. You can finance uncompensated care. You have that consistent payment structure across payers, which creates for a much more equitable system. But now it'd be very difficult to set that system up because we have these huge payer differentials. So that would be an issue moving into this. The cons, it's a tremendous effort to set up. It can be very complicated to do so. In fact, that's one of the big weaknesses of most of the rate setting systems is this concept of regulatory failure, that the systems became way too complex over time and no one understood the incentives and the systems devolved. There's also the hospitals, when you take pricing out of the equation, they tend to sink all of their efforts into either influencing the regulator or the legislature or the governor. So this issue of regulatory capture is a big issue. We didn't have some of these problems because, as I said, we had Medicare payment levels locked in, which are in Maryland about 20% higher than the rest of the United States. The reason why Maryland has persisted and no other state has been able to keep a system is largely fear of the alternative. The hospitals have the fear that if the waiver goes away, they'll revert back to governmental payment levels, which are much lower than they are currently in Maryland. So that's what's kept the system together, and it'd be very difficult to duplicate.
So this issue of disparities between public and private payments has come up a number of times and is at the heart of some of this. And it's one of these issues, this question of cost shifting, or is there cost shifting? We see a kind of disconnect between people on the ground, industry players, health plans, hospitals, and economists. It's probably not the only issue in healthcare where we see a disconnect between regular people and economists. But it's one that comes up a lot. So I want to sort of, Marty, you, I'm guessing as a card-carrying economist, you mostly don't buy that there's systemic cost shifting, or maybe you do. Where might we see cost shifting? Where might we not see cost shifting?
Yeah, Larry, that is really interesting because the scientific research evidence does not support the claim of cost shifting, the idea that, say, Medicare, Medicaid payments go down, and as a consequence, doctors, hospitals, whoever, increases their prices on the private side. We just don't see support from that in the research evidence, but folks in industry that you talk to, and you hear that. I was director of the Bureau of Economics at the Federal Trade Commission. We talked to a lot of folks in the healthcare industry, and they would certainly say things like that. So we don't see evidence for it, but one thing to remember more broadly is where the money comes from on the private side. So the vast majority of folks who are getting care through the private side are folks who have employer-sponsored health insurance. And employer-sponsored health insurance is part of total compensation for individuals. So if something happens like the prices of healthcare services go up, and that means the cost of providing that benefit goes up for employers, something's got to give. I know this sounds unbelievable, but I'm only worth a certain amount of money to Carnegie Mellon. And if the cost of, write my dean, by the way. If the cost of providing me with health insurance goes up, then either my pay increase will be less than it otherwise would, I'm going to pay a bigger chunk of the premium, or they're going to cut back on the benefits. And that's what happens, right? Worker wages have stagnated in the United States. This isn't the only reason, but one of the reasons is the rising cost of healthcare benefits. So when private prices go up, that comes out of workers' pockets.
Yes.
Well, Marty hit on the other issue where economists and the rest of the population don't necessarily agree, which is that the premiums that employers pay for insurance come out of workers' compensation. But we'll leave that one aside for a moment. Chris and Melinda, I mean, your members, charge these prices. Chris, your members pay these prices. I mean, how should we think about that process, and whether cost shifting is really happening when public payers are paying less?
Well, again, maybe this illustrates the difference between economists and real people, but who have to manage real hospitals. But when more than 50% of your patient population is the care is being funded by Medicare and Medicaid, and that they are underpaying, where do you magically think these dollars come from to make up the rest for the other patients? I mean, it's just. They have to come from somewhere. Now, tax-exempt hospitals do have a community benefit obligation, and so they actually spend a tremendous amount on free care, discounted care, and other kinds of community services. So you start looking at the delta for that, and you see that there has to be some kind of cross-subsidization if government isn't going to pay. If government isn't willing to pay, and again, Medicare and Medicaid are just not willing to pay the full cost of treating patients. So that certainly, and I don't think that the Blue Cross Blue Shield folks would argue that there isn't some cross-subsidization. We might argue whether it's a good thing or a bad thing, but there certainly, there certainly is. And again, I'm surprised to hear economists doubt that. Just because I think you can do the math and figure it out.
So just briefly, I'm not 100% convinced about the claim that hospitals or any other healthcare providers lose money on Medicare or Medicaid. These patients don't get turned away.
They can't get turned away. They
Not
can't. Every
not for the most part. You
has
just
an
told me they're half of
obligation.
your patient population. So how many are you turning away?
We're not-
These costs of nonprofits are not actual costs. I work at a nonprofit, believe me. I know. Just the statement of the previous panel, costs come up to meet revenues. That's always true in a not-for-profit. So I'm not convinced from the outset, and we have a difference of opinion. That's totally fine. That providers are actually losing money on publicly insured patients.
Providers are losing money. I mean, they've been losing money for. You look at any Medicaid programs. In fact, most Medicaid programs in most states will actually actively acknowledge that they are paying less than the cost. As a matter of fact, take Illinois for example. Not only do they pay less than the cost of what it takes to care of a patient, but they are 8 months behind in paying hospitals for their Medicaid patients. Who's going to make that up? That's not, the nurses, the technicians, the people that work in hospitals have to, are only going to work there if they get paid. So I just think it's almost beyond, beyond argument that there has to be some kind of subsidy, and that state and federal governments are not paying the full cost of care.
So Chris, what's your, if anyone's making it up, it's you. So.
Yeah, so I think we do share that concern about cost shifting from government programs. I think the question is, could we sustain a program where we're paying government rates to all providers? And I think if you think about it from that framework, you'd see a lot of significant issues with access to care here. We've thought about whether we should be looking at potentially being able to pay Medicare rates if there's market failure in an area where there's so much concentration that you can't negotiate effectively. In some ways, that's what Medicare Advantage does. If a provider doesn't agree to participate, you can pay fee-for-service rates out of network. But I think that's only something you can do in a very, very limited situation without creating some access issues.
Well, that issue was easy. Let's turn to a harder one, drug rebates. There's been this discussion recently about kind of the rebate approach to pricing and where those rebates should go. Jenny, you sort of touched on it a little bit, but didn't get into a lot of detail. What's your view about if that's the way drug pricing is going to work? List prices with rebates, negotiated rebates. What should happen to that money? Where should it go?
Well, I think. I'm trying to think where to start here. I'd say the rebating system has worked very well. I think it's already been referenced that it's worked very well in the sense that it's kept net price growth fairly low on average. And there's some classes of medicines where it's worked really extraordinarily well, and the net prices are now, say 70% below what the sticker prices are. I'd say it is a challenge for the industry that those classes where it's working best are actually the same classes where the industry gets attacked for rising sticker prices. And so there's definitely a challenge there in just the complexity. But I think our industry is interested in beginning to move away from this type of system. We don't think that it's healthy for payers just to be chasing rebates. We actually would like the competition to be based on something closer to the value of the medicine, and to have the prices be a little bit closer to what net prices are. And we think it's a huge problem for patients when they get caught in the middle here in these crowded classes where they're paying, in some cases in the deductible, for example, they're paying more than their insurer pays for the medicine. So the insurer is profiting in the deductible. It's kind of baroque and doesn't make sense. So we do think that the discounts should be making their way to the patients, or at least a larger share of them are. I think we're actually less rigid about how that happens than people would give us credit for. We think that there are lots of ways that we can move in the right direction here, and we think that having those discounts shared at the pharmacy counter in some way with patients will help change the incentives in the system overall in a healthy way. So I think that's I think that's sort of essentially where we are on the rebates. I'd say there's another sort of hidden story about what's going on with prescription drug cost growth, and it's related to this business we were just talking about with hospitals and whether consolidation is an issue. And we do see, I think, market-wide, a big shift in care to the most expensive settings, so out of the community into the hospital outpatient department. And we see that, for example, in cancer, leading to higher costs, not just for drugs, but across the board for all services. And what's interesting about that is that we come under a lot of attack as an industry about the cost of some of the medicines that are used in those physician-administered medicines that are used in those hospital outpatient departments. But I'm much less worried about the $1,000 drug where the physician makes $60 as an add-on payment than I am about the $1,000 drug where the hospital is billing at $2,500 and collecting more for that medicine than the manufacturer is even, and the fact that in very uncompetitive hospital markets, they can essentially load their overhead onto the prices for those already expensive medicines, and then that's seen as prescription drug cost growth for cancer medicines, and it's not actually a decision even made by the manufacturer. It's sort of a function of the cost to charge ratio and the fact that plans are paying based on a percentage of billed charges. So I think we have a lot of work to do to sort of unpack what's going on with the cost of specialty medicines in the hospital outpatient department.
So I'm going to get back to Chris and the rebates, but Melinda, did you have?
Well, absolutely, and I think a lot of what you just heard about prices being passed on really fails to appreciate exactly how high the prices are, and I expect you're talking about the fact that more physicians have wanted to join hospitals to provide infusion services, and there are a lot of reasons for that, and market power is about the least of the reasons. But pharma, and you made reference to this earlier, there's a program that actually was started, Congressman Waxman, it was Congressman Waxman's brainchild. When the Medicaid program first started requiring that there be rebates for drugs from pharmaceutical manufacturers, they quit giving rebates to safety net hospitals. And so Congressman Waxman actually had a vision and came up with a requirement that for hospitals that serve vulnerable communities, that the pharmaceutical companies would have to give the same discounts to those hospitals that they gave to the Medicaid program, and that has continued today, and it's actually been endorsed by Congress a number of times and expanded. But that's a really important program, and it's really important for hospitals because of the high price of pharmaceutical drugs. And again, these are hospitals that serve vulnerable communities that are able to get that discount. And the whole idea behind the program, which is still valid, but which pharma is concerned about because it really comes out of their bottom line profits, is that hospitals are getting the same discounts that Medicaid are getting, which allows hospitals, again, these safety net hospitals, to serve vulnerable patients in a multitude of ways. And it's a really important program. And if you read Politico, you notice every third day that pharma has something pejorative to say about it. But it's been a highly successful program that's really served patients for tax-exempt hospitals and safety net hospitals that otherwise wouldn't get the value of those kinds of, certainly wouldn't get those discounts and certainly wouldn't get the value of those discounts.
So I am sorry we only allocated an hour for this and not 3 hours for our discussion, because there was certainly plenty to talk about. Chris, I just wanted to get back to you on rebates, and I'm guessing you had just interested in your perspective on how effective that is in terms of a pricing approach, and should there be a change in where the rebate dollars are flowing to?
Yeah, I think this whole focus on point-of-sale rebates is a little overblown. Many health plans do offer the option to employers, and this is certainly the case for Blue Cross Blue Shield plans in the federal employee program, to get rebates at the point of sale, but there's a correlation between that and premiums. So when CMS has looked at providing rebates at the point of sale in the Medicare program, they've found that over the next decade that would cost about $28 billion dollars in terms of higher premiums for beneficiaries. The whole value of the rebates today for commercial plans is probably 12-13%. If you look at the amount that's spent from the MLR filings. And rebates are only good at the point of sale for a certain number of drugs that are covered through coinsurance, for example, and not through copayments. So really the focus, I think, needs to be on the list price of drugs, and hopefully what the administration announces later this week will take a close look at list prices as well as some of these other incentives.
Robert, let me bring you back in to focus a little more on the public sector. There's been a lot of interest in Maryland all of a sudden in the all-payer rate setting system. California has introduced an all-payer rate setting bill, which I think has produced more buzz outside of California than inside of California. But do you, in your experience, is Maryland a model for other states? Is this something that that would be, particularly given the different context from what existed several decades ago? Is this something states should be looking at?
To be quite honest, it's a very difficult model to duplicate. It has had a lot of success. I think there's success now in the current global budget model where they've met a lot of their requirements. The state has grown at the gross state product, the rate of growth of gross state product in Maryland, which is a feat. Contrary to what was said before, the hospitals, the rates that they've gotten have tracked Medicare payment increases over the last 5 years, and they've not gone out of business. The profitabilities have actually gone up. So it is a sustainable type of model to operate under Medicare rates of growth. The problems in duplicating the system, the one that I mentioned to you, I think absent rate regulation, states should look at setting maximum payment levels for all negotiated care, particularly for out-of-network care, because that's where there's the biggest imbalance between hospitals and payers when they negotiate, when they sit down to the negotiating table, and particularly in consolidated markets. If you're going to a hospital that's out-of-network in an ambulance, you don't know what you're going to pay. And that affects the negotiations between payers and hospitals. Whereas if you were to set a maximum level, as California has done in certain instances, but for all out-of-network care, you can cut off that excess negotiating leverage that the consolidated systems have and help restore some balance of competition into the industry. In fact, there's evidence to show in the MA market, Medicare Advantage, there is a law actually that says when hospitals and private plans that are MA or are sponsoring MA plans can't negotiate, the prices revert to Medicare fee-for-service. And as a result, the prices for the MA plans are much closer to fee-for-service. So there's evidence to show that that type of legislation could have an impact on pricing.
Marty, you talked about consolidation. You worked on antitrust enforcement. That's another area states have expressed some interest in recently. What do you think states and the federal government should be doing, and how far could that go in addressing prices?
Okay, sure. So again, this is a multifaceted question, and it includes a number of things. It includes consolidation, but it also includes practices or actions taken by industry participants that are anti-competitive. And so one should bear in mind those are particularly important as well. So the federal agencies have been very active. Some state attorneys general have gotten more active. California, in particular Massachusetts. So it's certainly possible. Another point is that if we want to have healthcare markets work as well as possible, there's no one policy lever. Antitrust is one, but there are multiple things. I do agree with one of the things Mindy said, in that we do have to pay attention to not just regulatory burden, but administrative burden. There are administrative burdens on the private side that can cause all kinds of distortion. Doctors who face heavy administrative burdens want to get out from under, and they're very interested in selling practices to hospitals, say, and that's totally understandable, but that's not because it actually makes things better. So I think we do need active antitrust enforcement. There have been many mergers in health insurance and pharma and hospitals and doctors, and then now we have all kinds of mergers between these industries as well. Most of those are perfectly fine. Most of those are not harmful, but they do need to be scrutinized, and we have so much consolidation already that additional consolidation is much more likely to be harmful. We need to pay attention to that. We also have anti-competitive practices. The pharmaceutical industry is known for innovation, and they've been extremely inventive in finding ways to thwart competition. So pay for delay, product hopping, patent thickets, refusing to supply drugs to samples to potential entrants. So there's all kinds of things that happen in that industry. Restrictive clauses in contracts between providers and insurers. There's a case in North Carolina about that right now. There's a case in Northern California. So that's another very important area for attention. Now, having said all of that, in some places, there's already been so much consolidation. I think Bob referred to this, the cow being out of the barn. I'm a city boy, so I'm not quite sure I understand what that means. I think I've been on a farm once. Anyhow, somebody stole it? Is that what? Anyway, but for example, my hometown of Pittsburgh is dominated by University of Pittsburgh Medical Center, Boston by Partners, the San Francisco Bay Area by Sutter, and the list goes on and on. It's very hard for Antitrust to deal with situations like that.
But those are really all the markets.
Excuse me, I'm not done yet. So we need to be thinking about other tools as well, and something like price cap regulation is something that we need to consider. Levers to open up the possibility of entry and competition, a whole bunch of different approaches.
So I'm going to turn to audience questions in a moment, but Mindy and Jenny.
Well, I'm an antitrust lawyer by background, so and actually I'm a big fan of the antitrust agencies, even though I'm half the time I'm mad at the Federal Trade Commission for something. But really, I think one of the successes that we've seen really is antitrust enforcement in healthcare, and we've seen the agencies. And in antitrust, there are two federal agencies on the job. At all times, and you also have the state attorneys general. So, so as we're bemoaning consolidation, every single one of those deals that has led to this, that underlie these markets, has been thoroughly reviewed by antitrust, by the antitrust regulators, both federal and state. And in the case of Partners, for example, in Boston, one of the transactions that they wanted to enter into was actually rejected by the state authorities. So, I don't think we can say that sort of the antitrust agencies haven't been on the job, and that whatever consolidation hasn't been thoroughly reviewed for its competitive potential.
I was just going to say that we've seen a lot of attention on specific examples where competition hasn't worked in the pharmaceutical industry. Like, there's been lots of poster childs over the last 5 years of problems, but it's really important to keep it in context, right? So over the last 10 years, I think 7 out of the last 10 years, healthcare drug spending grew more slowly than healthcare spending, right? And over the last 10 years, if you look at the National Health Account data and like what added to US health spending in total in aggregate dollars, drugs added about $100 billion. There was about $1 trillion added overall. Health plan administrative costs added about $100 billion too. And I would argue for the $100 billion in extra drug spending, we got a lot, right? Completely changed the paradigm, and cancer really made a lot of other huge strides. So just in terms of what our system does well, our system does actually continue to balance innovation and affordability. And overall, not that our system cannot be improved, because to be very clear, there's a lot that we need to do here to better shape the system for drugs, not just for all of healthcare. But overall, our system does still allocate resources to new innovations and new advances in medical care, better, I'd argue, than most other countries. So if you look at France, for example, we have twice as many new medicines for cancer available and used in the US as France. I think Australia has about 1/3 of the cancer medicines available. And I would say that actually, if you look at health outcomes for the conditions where having new drugs matters, we do better in the US. And I don't think that's something we want to give up. So I guess I would, just like looping back to where you were at the beginning of this day, like I think there's a lot that the US system does fairly well and that we want to protect, and that having, forcing prices down by restricting access, which is generally speaking the way the movie runs in other countries, is not really where we want to go.
Well, I'm quite certain that every comment on this panel could lead to a counter comment, and we could be here all day. I want to, Bob, you want to just make a quick comment,
just very quickly. At the beginning of this, you talked about this is a moment, and I don't want to depress anyone, but I can think back to 2003 when Jerry Anderson wrote his article about "The Price is Stupid." Moments like this every 2 to 3 years where they trot me out, talk about rate setting. It's great. I'm happy to add to my 15 minutes of fame. But this is a debate that's been continuing for decades, and it's getting worse and worse and worse. And the issue is we can't afford it. We basically just can't afford it. I mean, this innovation is great, and other things the hospital industries do are great, and doctors, but we just can't afford the system. And it's bankrupting individuals, it's bankrupting budgets, it's bankrupting the United States. We have another financial crisis, we're toast. So that's the issue here. I mean, otherwise, I'm happy to come back every 2-3 years and talk about this topic again.
But I think the movie Groundhog Day had it pretty much right. We can get up every morning and do it all over again. Questions from the audience, and Tiffany will come around with a mic.
Thanks. Hi, Alwyn Castle with Policy Translation. I want to ask Melinda Hatton about her first statement pointing to regulatory oversight as the big bugaboo in healthcare pricing, and the comparison you made between California and Louisiana. The last I checked, California regulated statewide, and yet hospital pricing varies dramatically in California between northern and southern. So I don't think that's the answer. I mean, consolidation may not be the answer, but all of these things play a role, and there is no straight line. I joke prices are high because they can be, because none of us has the political will to confront these issues and put some skin in the game other than consumers' skin in the game. None of you three up there have skin in the game because you all are making a bunch of money. Thanks.
I would say that I think all three of us are also consumers of healthcare. So yeah, we do have skin in the game. I assure you, we have big skin in the game, and I think we all have members who have skin in the game. And the comment I made about California and Louisiana, absolutely. And you could look at probably any hospital in California, and its costs and as a result, its prices are higher than Louisiana. California has an extraordinary regulatory apparatus. Just take their seismic requirements alone in California, and that's enough. That's enough to bankrupt a small hospital. And hospital prices vary by hospital, and you can't look at a northern southern California continuum and say that that's the reason. You have to look at the patient population they serve, the kind of hospital they are. An academic medical center. Somebody made lots of times Boston gets a bad rap for being consolidated. Boston is full of academic medical centers. Academic medical centers just cost more to run than a small community hospital, and as a result, the costs are higher. It just is. And depending on the kind of community you're serving, your costs are going to be higher. Depending on the medical practice there, your hospital costs are going to be higher. So you can't. I think when you make really generalized statements like that, you're not appreciating the granular reasons that one hospital is going to be more expensive than the other or have higher costs than the other. And there are lots of good and valid reasons for that. This isn't to say that the hospital field isn't very concerned about costs. We have a very aggressive value initiative going on because we recognize that consumers are paying too much out of pocket, and that and that more needs to be done across the industry and in the hospital field. But you really do have to look at individual situations. It's really hard to generalize.
Marty, you want?
So just briefly, scientific study after scientific study in peer-reviewed journals looks at these price variations, takes into account all the things Mindy talked about, which do drive differences in prices and costs, of course they do, but also finds that above and beyond that, the number of potential competitors nearby has a lot to do with price variation. So that's just one. Two, just very quickly, based on your question, what Bob said, my view on this is, as far as policy, is the following. All of us probably have been up on stages like this every few years. This comes up over and over again. We know what's going on. There's no shortage of practical, actionable, bipartisan policies that one could take tomorrow. Those are not the issues. The issue is political will. Competition does not have a constituency, and that's a problem.
Hi, my name's Tahir Amin. I'm from the Initiative for Medicines, Access and Knowledge. As a lawyer who spent most of my life, probably the worst part of my life, looking at pharmaceutical patenting, I'm surprised that a lot of the solutions are at the downstream end of this problem, and we don't look at the upstream part of the problem where actually all the power is gained. So we got into it a little bit with the antitrust stuff, I think Martin mentioned it, and the pay for delays and the various strategies that the pharmaceutical companies use to preserve their power and hold on drug pricing. And we've done various studies where we've looked at how they accumulate these thicket of patents to prevent competition. And I keep hearing the word competition. What are we going to do about releasing some of the power that pharmaceutical companies hold at the beginning of the process rather than waiting and trying to negotiate it at the end of the process when you have no power? So I think that's a fundamental question that I have when I look at this around the world and look at the problems that we're debating today. And I recognize, innovation is important and incentives are important. But I think there's a lot of stuff that's actually not innovative when you look at the patents and the rights that are being granted. And statistics show that 75% of drug patents are often invalidated when challenged. So I'd like to at least put that on the table as a solution.
Yeah, I think, again, I would argue that our intellectual property system is doing a very good job of making sure that we get new advances and that overall, we are also getting new generics and that we have a life cycle of products so that when they're at the end of their life cycle, they become a generic and they become cheap and used for generations. And we have 9 out of 10 prescriptions being filled with generics here, which is better than any other country in the world. Talk about something that the US does better than Europe and other advanced countries. It's making good use of generics. And we are at the beginning, I think, of what will be another wave associated with biosimilars. And not that there aren't bumps in that road, but the folks who estimate and project drug spending believe that we're going to have more savings from loss of exclusivity for both generics and biosimilars in the next 5 years than we had in the last 5 years. So it's a continuing story of a system that by and large works. Not that, again, that there aren't some things that have been criticized and that we're thinking about in the industry, and there's good reason for discussion, but really we ought to be trying to encourage other countries in the world to make as good use of generics as we have here, because that would create more room for them to actually play a little bit more of their share toward covering new medicines, which would help all of us and help mean that there's more investment in tomorrow's medicines.
Yeah, I think we can do a better job on patents, and one thing we can do a better job on is actually protecting the intellectual property rights of the innovators. So if a drug company actually innovates, they have a patent, that needs to be made much clearer exactly what their patent rights are. The patent office actually needs to do a better job than they're doing on that. And that could avoid some of the problems that we see that cause problems in this market. At the same time, we do see practices like patent thickets, and that has to be cut back or prevented. Again, the Patent Office can do a better job. The antitrust agencies can get on that a bit. But I think we actually need improvement in both directions, better protecting legitimate intellectual property, but not allowing illegitimate protections.
Hi, Dan Crippen. I'm generally described as a Washington has-been. One of the elements of that may be more relevant here than others is I once tried to run the Congressional Budget Office, and I emphasize tried. By the way, many of you are too young to remember an economist, I think it was at AEI, Herb Stein, who once said, and is famous for saying, if this can't go on forever, it won't. Unfortunately, Herb died before he told us when. So in that context, the levels of spending and even levels of prices between different hospital systems, between different drugs, are of course important, but we're here to talk about prices. And the question for me is not, can we afford what we do now? We're trying to do that. But it's the increases that are going to kill us in the future. So it's not so much all of the levels we're talking about now. Clearly that explains some of the differences between other countries and us. But what do you all think about price increases? What causes those increases, not just the differentials we're looking at across different countries or regions?
Well, I think big driver of price increases are just the market dynamic that it described, and each and every year, occasionally it flattens out when we talk about health reform or other threatening things to the consolidated hospital industry. But it's the market imbalance in purchasing and the negotiated price increases that are being driven in day-to-day negotiations between largely consolidated hospitals and payers that are more fragmented and don't have the purchasing power. There are various ways of addressing it. We talked about more competitive approaches. You have to do something to kind of stimulate that type of competition. And this idea of setting a maximum price obligation for out-of-network care would potentially do that. It would give the ability for smaller insurers to come into the market and provide some additional competition in that negotiating process. So again, the issue is how do you restore competition, and that would be one way of approaching it.
You know, I think it's lovely to live in Maryland. I noticed the head of the Maryland Hospital Association is now in California, so it'd be interesting sometime to have her tell you how different it is. And by the way, I don't agree with any of that, nor do I agree with that payers are fragmented. If we learned anything from the challenge to the Anthem Cigna deal last year, it was how much market power Blues plans have around the country. We were shocked when we started to look at that. So, not that much fragmentation. There's a little less fragmentation, I think, than you might think. But you know, one of the things about prices, and one of the things that we hoped, and why we were so, why we supported the Affordable Care Act, is that we could move from volume to value, and that really would have an impact on prices and quality. And we've been big supporters of, I'm just going to call them quality, of new models of care that reward quality and reward outcomes. And I think if there's anything that's really going to change the dynamic here, it really is more experimentation with those kinds of models. And Medicare Advantage is sort of one of those models, and actually has been pretty, I would say, has been pretty successful and has had a pretty good uptake among beneficiaries. I think a surprisingly good uptake among beneficiaries. But that's what really may change the dynamic. And we were really pleased to hear with the new Secretary of HHS that they're still committed to new value-based models. They want to experiment with some different value-based models, but they're committed to it, because I think that's what I think really will change the dynamic. Value-based models that encourage coordination, that reward performance over instead of a fee-for-service kind of reimbursement system. But that's what we're working toward. That's what we're very supportive of, and hope that both the administration and the private sector will continue to sort of embrace those kinds of experiments.
And Chris, you want to jump in? Then we have time for one more quick question.
Yeah, I would just add, I agree with that, the points about trying to move more towards a value-based payment arrangements. We are very supportive of the Medicare Advantage program and that model, but I think that this issue of paying fee-for-service rates out of network really does have to be used with caution. It really could disincentivize the health plan's use of more value-based arrangements if you're not careful with that. So I think there's kind of a limit to how much you want to do that in the market too, and it really should only be in areas where there truly is market failure.
Okay, one more question, and then we'll make another quick switch.
Thanks. I have a question about Part B prescription drugs. One of the reform efforts that we've heard about is the consolidation of those Part B prescription drugs under Part D. And I was just wondering if the panel would weigh in on whether y'all think that that's likely to be an effective strategy.
Chris or Jenny?
I can take a first time and let you talk about it. I mean, Part D certainly is an effective model for competition. We understand why people would want to move as much into Part D as you could. I would argue, though, that it is really challenging to look at the medicines that are currently covered by Part B. They're very different kinds of medicines, and the Part D plans are not all that well set up to, they don't have relationships with physicians. I think it could be really disruptive of patient care to move a lot of those drugs into Part D. I also think that there are many, many unanticipated questions associated with that people haven't even thought about. Like, what would the increase in Part D premiums look like, which would so swamp what we've been talking about with the increase in premiums associated with passing through a portion of rebates at the point of sale, which, by the way, would lead to savings in Medicare Parts A and B because patients would stay on therapy. But so I would exercise substantial caution in trying to just simply move B into D in that simplistic way. And I think that as people look at it more closely, they're going to be concerned about doing that.
Chris,
Yeah,
and Marty, you get the last word.
Yeah, no, go.
It's certainly something that we'll be looking at closely when this comes out. I share some of the concerns that Jenny has about moving drugs from Part B to Part D and the impact that would have on premiums, but there may be instances where that competitive model could actually drive down cost as well.
Yeah, just briefly, I think the issue is less whether it's Part B and Part D and how Medicare pays for it. So we heard earlier, I think it was Patricia, say something about the way Medicare pays for it. So basically, they're overpaying doctors for administering drugs, and not surprisingly, the incentives are bad. Now, would that be improved by moving into Part D? Possibly. But again, I would concur with the opinions that were just expressed. It's not a completely simple matter, and the point is that it could stay Part B, but just the payment mechanisms could be improved. Just one last point about payment reform, payment innovation on the private side. There's evidence that innovative payments happen a lot less when there are a lot more competitors nearby. So if there are dominant providers, they have the power not just to negotiate how much higher prices, but how they get paid. And they negotiate basically a percent of charges, which are more favorable to them than retrospective payments or bundled payments or what have you. So again, one can't ignore the market environment in even thinking about how providers get paid. It's not just how much, but it's also how.
Well, thanks. As I said, I'm pretty sure we could go round and round for forever on these questions, as we have done. But please thank incredibly knowledgeable and respectful panel. So we're going to make one